When we look back at the data from ASH, there's a few highlights, I think, many highlights. First, in the newly diagnosed patients, the triplet of daratumumab, lenalidomide, and dexamethasone, so DRD in the transplant ineligible patients, having a PFS of over 50 months, that's really quite dramatic. And that result really resonates, I think, with us, our practice, and we are trying to go to DRD now as our main frontline therapy in the transplant ineligible population. And those data actually compare, and it's hard to do cross-trial comparisons, but it compares nicely, honestly, to all the RVD data, no matter if it was transplant ineligible or transplant eligible. And it's actually, it compares, to the KRD data too. Also in the newly diagnosed, we've always been fans of the FORTE trial. We tend to use a lot of carfilzomib, especially in what we would consider high-risk patients or young patients, because we think they can tolerate it no problem. So KRD has often been our frontline therapy. And after patients get KRD and a single autologous transplant, and typically we give them a little KRD consolidation, the question has always been, do we give them KR for maintenance, or do we just give them R for maintenance at that point in time? And it was really nice seeing at the FORTE trial that where patients had a second randomization, and they were randomized to receive either carfilzomib plus lenalidomide versus lenalidomide as the maintenance therapy. And essentially more patients went on to achieve MRD negativity in the KR versus the R group. And it actually was across almost all subgroups. It was in the ISS stage 1 and 2 versus the stage 3, and it was in the low risk versus the high risk, and in the young versus the old. Kind of everybody benefited, which is pretty nice to see. So I think our maintenance therapy, especially in high risk, is certainly KR now rather than anybody considering R as a maintenance-based therapy. And even in the, not just high risk, but even in the standard risk patients. In the relapse refractory, I think it's still, a lot of that is still just, I call it, it's the artist who's painting the picture, because you can put so many different pieces into that piece of art, and you can do it in sequence. So the sequences that we use are quite different. Typically, if we do not use a daratumumab regimen for frontline therapy, we certainly are going to a daratumumab regimen as first relapse. Based on the IKEMA data and also on the CANDAR data, I think we're now more attuned to doing either daratumumab or isatuximab plus carfilzomib and dexamethasone as first relapse, especially in those patients that are on lenalidomide as maintenance-based therapy. Now, daratumumab is approved with carfilzomib in the weekly dosing, and we actually have an expansion cohort of a phase 1 trial at UCSF that's testing isatuximab with weekly carfilzomib. And so we try to actually put patients on that study, which is great. But if patients, for whatever reason, they don't want to come to the center because of COVID and all the other stuff, then daratumumab, pomalidomide, and dexamethasone is a good regimen for us also. And then, honestly, probably the 7 other splashes from ASH are all in the relapse refractory, the immune-based therapies, the bispecific T-cell engagers, and the CAR T-cells. We had some amazing presentations with not just BCMA-targeted bispecific T-cell engagers, which there are, a handful of them, but we also had bispecific T-cell engagers targeting GPRC5D, a different cell surface protein, and FcRH5. The number of drugs, the new drugs, the exciting new drugs that we have coming down the pipe for myeloma it seems endless. It seems endless. And it's really going to be amazing over the next 5 years on how we go about moving these drugs from the truly relapse refractory to the less refractory, and then eventually to frontline, and then even in smoldering. These are all going to be great drugs to test in all those scenarios.